guys, welcome back to my channel. My name is Khadijat Adeshola, and in my channel I talk about everything related to women and midwifery. So if you're new to my channel, if this is the first time of coming across my channel, please kindly stick around, watch this video to the end. If it's something that you like, please don't forget to like, comment, share, and subscribe to my channel. When you subscribe, don't forget to turn on the notification button so you get notified whenever I post a new video. To all my returning subscribers, thank you so much for subscribing. I really do appreciate your support, and that is why I'm still here. So today I'm going to be talking about the new midwifery OSKE assessment station. So I have an assessment station on my channel already, but as we all know, there are recent changes on the NMC midwifery OSKE, and the reason being that, like as stated on NMC website, that they are making changes on the OSKE just so that people don't get the same question whenever they go for, the OSKE. So it's been like a monopoly before, like most likely know what the questions may be like. But for now, they've now added lots of, areas which prospective candidates are going to be tested on. So the probability that you will get the same question that that recently did or that did before you got it, is quite slim at the moment. So it's expected that as a new, as a candidate, as a prospective candidate for the NMC midwifery OSKE, you should be aware of the all area that you might be tested on, and you should try as much as possible to master each and every one of them. So you need to really prepare well for your OSKE, and I wish you all the best. Don't forget that I do provide one support for midwives who are preparing to sit for their OSKE as well. So if you want a one-on-one support from me, you can always, signify. This send you, the details and everything that is included. So if you register to be to have a one-on-one mentorship or training support from me, you have access to me throughout until you actually pass your OSKE, and I'll be there to answer any of the questions regardless of where your test center is. So that's that for that. So this video, I'm going to be talking about the assessment station. However, currently there are three aspects that you can be tested on either of the three anyway on your NF for your assessment station for the API. So the question could be in any of this category. It could be a question related to antenatal admission. It could be question related to labor and birth, and it could be question related to postnatal. So these three areas you could be tested for in your NMC midwifery OSKE. So now, as we all know, the API are always linked stations. So assessment, planning, implementation, and evaluation. When you're given the question, that particular question or that particular scenario, you have to treat all of them treat that scenario in the O4 station. I'm sure everyone understand that anyway. So now, the assessment station for the three categories, they are similar. However, there are little differences which I'm going to be saying on this video as well. So how you answer the assessment station in this new midwifery OSKE depends on the scenario you are being given, or depend on the questions you're being given. So if you're giving question on antenatal admission, that everything you need to do, it still has to be the antenatal assessment station I did earlier. So if you check the videos on my channel, you see midwifery OSKE assessment station. So that is for the antenatal admission. It's still the same thing. So you still have to do the, establish rapport with the patient, confirm you're with the right patient, confirm if the patient have any allergies, confirm what complaints the patient actually brought to what complaints or what brought the patient to the hospital. Then introduce, of course you will have introduced yourself anyway. Then after that you perform full antenatal assessment, which includes you know blood pressure, vital signs observation, that's blood pressure, temperature, respiration, oxygen saturation, pulse, and abdominal palpation and urinalysis. Then you confirm the woman is having, is happy with the baby fetal movement. Then you document on the male's chart, that's modified early obstetric warning sign chart. Then you calculate your total mere score. You verbalize your score to the examiner at the end of the day, and you tell the examiner what your plans will be. And also, if you still got time, you explain the situation to the women and you let her know that she can always reach you or press the buzzer if she needs anything. That's for the antenatal question, admission question. However, if you're given question on labor and birth, so now they can actually create the scenario or make the question in different ways. So it depends however they coin the question or however they constructed the question. You will be able to know if this is a question of labor. For instance, now if they give a question that the lady or the woman is 10 and she's been having contractions about you know 3 in 10 or 4 in 10 lasting for 40 seconds, lasting over 40 seconds, which started like maybe about 8 hours ago, and this particular person is gravida 3 para 2, all normal, all previous normal delivery. Of course, you know that this is a kind of labor case. So of course you won't be able to really ascertain until you complete your full labor assessment. So in this scenario now, that's a kind of labor and birth scenario, kind of. So you have to like assess the scenario. You have to do a complete or full clinical labor assessment. Clinical labor assessment is different from antenatal assessment, meaning in this case you have to do some assessment that are labor specific. So, and the most important one is vaginal examination, which is labor specific, really. So, for in antenatal, you won't be expected to do a vaginal examination, or you won't be able, you won't be expected to, assess that or all of that. Now, it depends on how the question is constructed, I said earlier. But I do expect that you will need to do a vaginal examination when you're giving a labor and birth, scenario. However, when before you start the scenario, they will have given the station, they will have given you the equipment, everything you need. So if for instance you're seeing a sterile glove in the equipment that they provided, you should know that yes, you see a sterile glove, you're seeing a gel, you should know that you will need to really perform a vaginal examination in that station. Now let's give a kind of scenario on that now, as I said earlier. So you're given a question that the lady, she's gravida. Let me say Annie. Annie is gravida 3 para 2. She presented to the, whatever unit at to the labor ward or to what unit they say you are, with history of with complaint of contractions or lower abdominal pain or tightness that come that comes about 3 in 10, lasting about 40 seconds, and it started since last night, so maybe like 12 hours ago. And she is gravida 3 para 2, two previous normal delivery. Pregnancy has been low risk all through, and she is 40 weeks today. So like gravida 3 para 2, 40 weeks, low risk pregnancy, contracting, that's the question. So if you're given this kind of scenario or this kind of question, You approach, of course, you assess you introduce yourself to the patient to establish rapport. So hi, my name is Khadija and I'm going to be your midwifer today. How are you feeling? Can you please confirm your name? Okay, your name is Hani and your date of birth. Okay. Can I just confirm that with your wristband? Oh, that's fine. That's correct. Hani, date of birth, first, 1996. Do you have any allergies? Okay. So I understand you coming with you are 30, you are 40 weeks pregnant today, and this is your first pregnancy, and your fourth pregnancy, your third pregnancy, and you have two previous vaginal delivery. Was there any concern during the delivery? Nothing, everything was fine. Okay, that's fine. And how since when did the pain started? How long have you feeling the pain? Okay, since last night. That's about 12 hours ago. Okay. And how often are you feeling the pain? About 3 in 10. Are they really very strong, like very painful? Okay, do you need any pain relief at the moment? Or you're still able to cope? That's right. Down below, is there anything coming out? Any vaginal bleeding, any discharge? You think your water has gone or something? No, your water is still in car. Okay. Any bleeding? No. Okay, that's fine. And you happy with the baby movement? Okay, that's fine. So I'm just going to, do some assessments on you. So I'm going to check your blood pressure, temperature, respiration, and also I'll be needing to do an abdominal palpation and also vaginal examination just to check if if you're already in labor and how far you have gone. This is not your first pregnancy, so you know how it feels. So there's probability you're in labor already, but I'll be able to confirm that with my vaginal examination. And also I'll listen to your baby for 1 minute. If I have any concern, your pregnancy is low risk. There's no reason for me to connect a CTG at the moment. But if I have any concerns with the baby or you have any concerns with the baby movement, we might need to put you on the monitor as well. Okay. But before that, do you want to go to the toilet? If you want to go to the toilet, because vaginal examination and abdominal palpation might be quite discomfort if your bladder is still full. Okay, that's fine. So if you go to the toilet now, while I prepare my instrument, and I'll be back. Okay. Before I come back, if you need anything, you can always press the buzzer. All right. Thank you. Then I go back now, get my stuff ready. Of course, the blood pressure stuff to to check the vital signs, and also the gloves for the vaginal examination, which is a sterile gloves, and the gel. Also, I will be needing the sonicate to listen to baby, and yeah, an apron if you want to use that. What else do I need? Okay, that's all I need. So I go back to, what's my patient name? I come back to Annie now. So honey, I'm back. Are you still happy for me to go ahead with the assessment? Okay, that's fine. So I'm going to put this to check your blood pressure first, then check your vital sign first. After that, I do abdominal palpation, then we can do the vaginal examination. Is that fine? So I'm going to provide privacy, and I'm just going to, I've selected the right curve for you. So next to check your blood pressure. Don't forget these other examinations, don't forget not to spend too much time there, because in this station that's not really the significant thing. So you just have to do it really. And so you put the blood pressure, and don't forget you're using a mannequin as well. So you're not meant to spend so much time, because you will definitely not get any result. But they just want to assess you to be sure you know how to do this thing. So after wrapping the blood pressure cuff on the arm, of course you engage the lady that, oh, I'm putting in the, I've selected the right cuff for your arm, and I'm going to put it like 2 centimeters away from your, cubital fossa. What's that? And it's reading. Okay, that's fine. I've read your blood pressure. The next thing, I'm going to put this pulse oximeter on your finger to check your pulse and oxygen saturation. I'm going to check for capillary refill time first. Okay, it's perfect. I can use this finger. There's no any signs of inflammation or anything. So I pop that in there. Now I'm going to check your temperature. So if you're using the infrared here, if you're using the tympanic, if you're using the axillary, anyone, you put it, check the temperature, then you read the respiration as well. Then after that, okay, so honey, I want you to be in a I'm going to position you for the abdominal palpation now. So I'm going to the head of the bed going to be raised a little bit for the palpation. Why? When I'm doing the vaginal examination, I want the bed to be flat. Don't worry, just going to be doing the examination. After the examination, I'll reposition the bed if that's fine. Okay. So I'm going to palpate now, do a fundal palpation. Okay, I've worn my hand. If you want to wear gloves, to wear gloves, but it doesn't have to be. You don't need a sterile glove for abdominal palpation. So you wear your latest glove if you want to. So you do the palpation. Maybe you should just do the wear the latest glove anyway, if because or you can confirm from your examiner before starting the station, because you only have 20 minutes to do all of this, so you have to be sure of what you are doing and be as fast as possible. So you do the palpation, further palpation, okay, to set the lie, lateral palpation, and pelvic fluctuation to confirm the presentation of the baby. And also you check for the engagement, what part of the baby has entered, how many percentage of the baby head has entered into the pelvic frame. Then after that, the next thing you do is you want to perform vaginal examination now. So you discuss with Honey. Honey, I'm done with the abdominal palpation. No, sorry. I'm done with the abdominal palpation. I'm going to listen to your baby now, if that's fine. So I'm going to use the sonicate to listen to your baby for complete 1 minute. So I put the sonicate in the listing. I'm going to palpate your pulse as well. As I'm doing the to be sure I'm actually picking the baby's heartbeat. So it's 1 minute now. I've read that. The next thing I'm going to do the vaginal examination. After the vaginal examination, I'm still going to listen to your baby again to check if the baby is reacting to the examination fine. Okay. Do you need any pain relief for the examination, or you're okay? Do you want to use gas and nail or something? Or you're okay with vaginal examination? Okay, that's fine. So I'm going to wear the sterile glove now. So I can request for assistance from my examiner. Yeah. If you are doing a vaginal examination, if you need anything, you can request assistance from your examiner. You can request that your examiner help you to open the gel in your finger. Don't forget that this is a sterile procedure. You have to wear the glove, the sterile glove, to by and ensure you are maintaining sterility. You have to make sure you've positioned the lady before wearing your sterile gloves. And also, another thing we do in the clinical area is to put the gel on the sterile parts, and that the cover of the sterile glove. You can put the gel in there if you don't have an assistant. But if you forget to do that before you wear your glove, you can actually ask your examiner politely to help you to put the gel in your finger. After that, then you've already positioned her. Then now you go in with your, of course, we know how to perform vaginal examination. So you perform your vaginal examination, then you communicate the findings with the woman. You tell her, oh, okay, I've done the vaginal examination now. I think you're in labor, you're 4 centimeter dilated. Don't forget that the examiner is still going to give you, findings. So, but you can just try to, communicate with the lady, okay? And your baby head is down, I can still feel the membranes are still intact, it's not opened yet, that's fine. Okay, another thing I need to do before I do vaginal examination is to palpate contraction. You're meant to palpate contraction for 10 minutes. Of course, you won't wait there for 10 minutes. The examiner just wants to be sure you know how to palpate for contraction. You're palpating for contraction from the fundal area, really. Yeah, you note when they start and when they finish and how many she's having, in 10 minutes. So after the examination, you discard all your instruments and you wash your hands and you make her comfortable. Another thing you need for examination is they call it inco sheet in my space, in my trust, but 90, we call it nightingale back home. So you can call it anything you want, something, a disposable, sheet that you put under when you're doing the examination so you don't soil the bed. So make sure you put that as well. You want to get a pad as well in case anything is coming out after the examination to clean her up as well. So you make her comfortable bed, you put the bed how it's meant to be, and don't forget to listen to the baby after the vaginal examination. And that is the end of the assessment station for labor and birth summary. Then you now go to document. Where are you documenting now? You will use the meal charts to document. Yeah, of course. So in the meal chart, you're documenting the temperature, respiration, blood pressure, oxygen saturation. There's a space for you to document if the water has gone as well. So if the membrane are still intact or not in the new modifier early, you just look at what is in the chart and just document accordingly. For labor and birth, depending on how dilated the woman is, you may be required to use a pathogram as well. Once the woman is 4 centimeters dilated, you are expected to start a pathogram. So in the pathogram, there is a space for you to put on the fetal heart rate, just like the pathogram we use back home as well, but there could be a little differences. So the fetal heart rate, the contractions, and fetal heart rate, the contractions, membrane, vaginal examination findings, descent of the baby, head, blood pressure, temperature, yeah, and the urine that is passed, volume of urine that is passed. So, however, during this scenario, they might decide to give you just the pathogram because everything you're documenting on the mail's chart is already on the pathogram. So you may be asked to use the pathogram or you use the mail chart. So just be aware to use the appropriate documentation tool that is being provided for you. Remember, if you do a vaginal examination and it's more than 4 centimeters, you will need to use the pathogram. And also, you need to note on the pathogram whether she used hentonos or something. So they're going to, and that will be the end of the assessment station for labor and birth, summary. In labor and birth scenario, in that case, you perform a full clinical labor assessment, and also you discuss the finding with the woman and identify if there's any, cause for concern. That is it. Now, if you're given a postnatal scenario in the assessment, a postnatal scenario, that is, it could be like a postnatal visit, like you attend a patient at home, you do a postnatal visit or something. So that will also need you still need to do an assessment. So in postnatally, you also have to establish rapport with the lady, introduce yourself, all of that, to confirm you're with the right lady, confirm any, if there's any significant medical history. Now, after that, you confirm how the delivery was. Is it vaginal? Oh, you have a vaginal delivery. You have a cesarean section. Okay. Are you on any medication at the moment? Is baby feeding fine? Are you happy with the baby feeding and all of that? Do you have any concerns with breastfeeding? Is all of everything is fine? Okay, that's fine. So I'm here. I'll perform a full, head to toe assessment postnatally. You look at her. Uh, you do a vital signs as well: blood pressure, temperature, respiration, oxygen saturation, and what's it? Pause. Then also you assess low care in her, and if she has had a vaginal delivery or any perineal, sustained any perineal injury, you ask her if she's happy for you to see it, because some people are not, they'll just say everything is fine. They don't think it's necessary for you to see it. So you seek consent for that. If you want to, you also check the pad as well. If she complain of anything, if there's any concern, you can ask her how often is she changing the perineal pad, and how often, and tell her how often she should be changing it really. In this case, you can also do palpation to see if the uterus is, contracted. But of course, if she say everything is fine, she's feeling well, and there's no concerns with the observation that you did, that might not be significant. If she complains of bleeding or anything, clot, passing clot, you want to confirm if the uterus is contracted. If there is raised temperature, you want to check how raised the temperature is, and think of postnatal sepsis and escalate as appropriate. Okay, so and you also plan. So yes, after I think we understand this now. So in this video, I've talked about the three scenarios that you could be given in your assessment station and what makes it different. So in antenatal scenarios, you will be expected to do the full maternal observation, abdominal palpation, urinalysis, and also ask about fetal movement and if there's any PV lost. In labor and birth summary, you do full maternal observation, fetal heart rate auscultation, abdominal palpation, vaginal examination, and you document and plan accordingly. So in that aspect now, your planning may be like your recommendation of planning or what you need to do. So if she is in, let me say, in labor now, you have to listen to the baby. If it's low risk pregnancy, you have to listen to baby, auscultate baby heart rate every 15 minutes in first stage of labor, every 5 minutes in second stage of labor. If it's high risk pregnancy, you want to put her on continuous ETG monitoring, you want to call for obstetric review, you want to ensure bladder care, you want to do bladder care, analgesia, hydration in labor, escalate any concerns, ensure she's, want to do all those labor care. If she's postnatal now and you have you suspected of sepsis, so she needs obstetric review depending on where you are. If it's in the community, you have to call the ambulance, postnatal sepsis, and when they are coming, they come in with things you need to cannulate her, because you need to cannulate her. You need to take blood, you need to get, you know, uh, IV fluids and IV antibiotics. If it's in the hospital as well, you need to inform the senior midwife and for obstetric review within 30 minutes or immediately. You take blood as well. You explain to her she needs to be admitted. You give her prescribe analgesia, prescribe antipyretics and antibiotics. You take blood samples for investigations and all of that, and ensure that someone is taking care of the baby. So those will be your recommendation depending on the scenario you want. So if you have any questions or any clarification regarding this section, please don't forget to to comment this on this. And also, if you are currently preparing for your NMC or OSKE midwifery and you need more clarification or more support, don't forget to send me an email and I'll be there to support you. That's not for free anyway. So thank you so much for watching. I'll see you in my next video. Bye.